In patients with mitral stenosis, take note of ethnicity to consider endemic regions of rheumatic fever. Dyspnea may reflect pulmonary hypertension or pulmonary edema. Cyanosis may reflect pulmonary hypertension. Bruising may indicate anticoagulation in the setting of atrial fibrillation or a mechanical prosthetic valve. The stenotomy scar alone may suggest previous valve surgery. Look for intracardiac devices, such as a pacemaker or defibrillator in severe heart failure. Examine the hands and arms for stigmata of infective endocarditis, peripheral cyanosis, pulmonary hypertension, and signs of connective tissue or chronic inflammatory diseases. Look for anemic palmar crease pallor related to valve hemolysis or anticoagulation. Patients with severe mitral valve disease are often in atrial fibrillation due to left atrial volume overload and dilation, causing an irregularly irregular pulse. A small volume pulse may be found due to narrow pulse pressure and reduced stroke volume due to severe mitral stenosis. A narrow pulse pressure can be seen in severe mitral stenosis due to reduced left ventricular filling. Examine for anemic conjunctival pallor related to hemolysis and anticoagulation. Malar flush can be due to compensatory vasodilation in low output heart failure and mitral phases due to cyanosis in pulmonary hypertension. Look for poor dentition as a risk factor for infective endocarditis. A hoarse voice may rarely be present due to recurrent laryngeal nerve compression by an enlarged left atrium. Look for signs of pulmonary hypertension, including an elevated jugular venous pressure. In mitral stenosis, the apex beat can have a tapping quality due to palpable mitral valve closure. Assess for a right ventricular heave and palpable second heart sound, which are signs of right ventricular failure and pulmonary hypertension. Move on to auscultation, starting at the apex. Mitral stenosis is best heard with the bell of the stethoscope or pressing more lightly with more modern stethoscopes. Mitral stenosis is a low-pitched, rumbling diastolic murmur. An opening snap can be heard at the apex, while leaflet mobility remains intact. It becomes earlier and eventually disappears with more severe disease. A loud first heart sound is classic in mitral stenosis, but can be soft as disease progresses. Listen for a pathological P2 of pulmonary hypertension. A fourth heart sound is rarely heard due to right ventricular hypertrophy and increased wall stiffness. Additionally, listen for secondary murmurs related to pulmonary regurgitation, known as a Graham-Steele murmur, or tricuspid regurgitation secondary to pulmonary hypertension. We'll now go through a few maneuvers to accentuate any murmurs or irregularities. To accentuate the murmur, ask the patient to roll on their left side, listening over the mitral valve during expiration. Mitral stenosis is accentuated by expiration and leg raises, or squatting, and diminished by Valsalva maneuvers. Listen to the lungs for any pleural effusions or crackles suggesting left heart failure. Palpate for hepatomegaly, pulsatile liver, or ascites which may be present with pulmonary hypertension, tricuspid regurgitation, and right heart failure. Assess the lower limbs for edema related to right heart failure. When summarizing your findings, consider the causes of mitral stenosis and the consequences such as left and right heart failure.